This is Michael Melman. Now we're going to talk about reproductive anatomy. So in the USMLE, the gonadal drainage is very important anatomy-wise when it comes to the reproductive system. The gonadal vein is just a generic term that refers to the testicular vein in a male or the ovarian vein in a female. The absolute highest yield point that needs to be driven is that the drainage on the left side, so the testicular vein in a male or the ovarian vein in a female, on the left side first goes to the left renal vein before it goes to the inferior vena cava. Whereas on the right side, the right gonadal vein, being the testicular vein or ovarian vein, goes straight to the inferior vena cava. So on the left side, it first goes to the left renal vein, then the inferior vena cava. On the right side, straight to the inferior vena cava. And as we'll talk about later, that has clinical significance with regard to the formation of varicocele. So now we look at the lymphatic drainage, and another very high yield point is that the para-aortic lymph nodes are the first site of lymphatic drainage for the ovaries and testes. So fortunately, regarding this anatomy, you can just easily memorize it, and it's also very high yield. The reason this is significant is because any ovarian or testicular cancer, if they ask you about the site of metastasis, the answer will always first be the para-aortic lymph nodes, also known as retroperitoneal lymph nodes. Don't confuse that with the lymphatic drainage of the scrotum. The testes go straight to the para-aortic lymph nodes, whereas the scrotum goes to the superficial inguinal nodes. Also, for the female anatomy, occasionally you'll get asked a question asking about a metastasis from one of these sites, okay? The USMLE will frame the questions in a clinical context. They're not just going to say, what's the lymph drainage of the vulva? Okay, those types of questions are pretty rare, those one-liners. But as I just mentioned, they might say there's a lesion on the scrotum, and they'll ask where it's going to metastasize to, and it would be the superficial inguinal nodes. Now, as I said before, don't confuse that with the testes, because students will commonly memorize testes goes to para-aortic, because that's very high yield, and then they'll get a question about scrotal lesions, so something on the skin, and they just think it's a buzzword, and they immediately go to para-aortic, but it's wrong, okay? They say scrotum, the answer is superficial inguinal. If they say testes, testicle, such as seminoma on the testicle, it goes to para-aortic, okay? And for the context of step one, you don't need to know the fact how it relates surgically, but just for the sake of clinical relevance, when you're performing an orchiectomy, if you're removing a testicle, you do it through the inguinal canal. You never cut the scrotal skin. And the reason you don't do that is because you don't want to have the lymphatics from the scrotum mixed with the lymphatics from the testicle in case there is going to be a passage of tumor from one region to the other. Okay, so that's the surgical relation, is that you don't want to cut the scrotal skin because the lymphatics are different. But for the step one, they'll merely ask you about the site of metastasis being scrotum versus testes. Very high yield. Okay, that's why I'm reinforcing that. And similarly, the distal 1/3 of the vagina and the vulva. Okay, so any vulva lesion or any lesion distally in the vagina. The proximal 2/3 of the vagina and the uterus go to the obturator, external iliac, and hypogastric nodes. And once again, this isn't just simply let's memorize the lymph drainage of the first third of the vagina or middle third of the vagina goes to these respective nodes, okay? So they'll say you've got unopposed estrogen in a woman who's 57 years old. She's peri/postmenopausal, and we're worried about metastases to which of the following nodes if she develops cancer. And you'd have to know unopposed estrogen is the biggest risk factor for endometrial cancer. So we'd be talking the uterus, and that the answer would be obturator, external iliac, or hypogastric nodes, okay? And if they mentioned a tumor of the middle of the vaginal canal, that would be synonymous for the middle third. They said proximal 1/3, you'd know obturator, external iliac, or hypogastric, okay? This slide, this information right here is just easy points, okay? It's just easy points on your step one. Now for the flash quiz. The gonadal vein goes to renal vein, goes to inferior vena cava. Does this represent the left or right gonadal vein? As we talked about, it represents the left. It's extremely high yield. The gonadal vein on the right will go straight to the inferior vena cava, but on the left, it goes first to the renal vein and then to the inferior vena cava. So now we're going to talk about the high-yield gynecological ligaments. All right, so we've got the suspensory ligament of the ovary, which connects the ovary laterally to the pelvic side wall. Once again, the USMLE is not, or I should say rarely, going to ask you which of the following ligaments connects the ovary to the lateral pelvic wall. Okay, it's going to ask you clinical relevance, and they might say that there's a surgeon who is performing an oophorectomy. He's going to be removing the ovary, and they want to know the best answer for which vessels he needs to ligate. Okay, and that would be your ovarian vessels, because those are contained within the suspensory ligaments of the ovaries. And the other thing USMLE really likes, I don't know why they really like this, but it's very high yield, is that the ovarian vessels come from where? Where do they come from? Okay, so the ovarian vessels are branching directly off of the abdominal aorta, so around L2, and they don't want you to mix that up with the uterine vessels, for instance. So whereas the ovarian vessels are coming directly off the abdominal aorta, the uterine vessels are coming off the internal iliac, which comes from the common iliac, which comes from the bifurcation of the abdominal aorta, or roughly L4, L5. Okay, so the ovarian arteries, or I should say testicular arteries in a male, gonadal arteries come from the abdominal aorta directly, whereas the uterine vessels, they emerge based on the abdominal aorta bifurcation to common iliacs. Common iliacs go to internal and external iliacs, but the internal iliacs will give rise to the uterine vessels, okay? Whereas your external iliacs are going to go to femoral arteries, etc. But the cardinal ligament, which connects the cervix laterally to the wall, is going to contain these uterine vessels. Whereas our little high-yield tidbit about the ovarian vessels is that they branch directly off the abdominal aorta. So one of the high-yield tidbits about the uterine vessels is that the USMLE wants you to know their relation with respect to the ureter. So you have the ureter, which connects the kidney to the urinary bladder, and the ureter passes posteriorly to the uterine vessels in a female and the ductus deferens or vas deferens in a man. You can remember that because ureter and uterine vessels both start with U. Okay, don't confuse and say water under the bridge. Ureter passes behind the ovarian vessels. It's wrong, okay? The ureter passes posteriorly / under the uterine vessels in a woman, water under the bridge, whereas the vas deferens in a man is what will lie in front of the ureter, okay? So water under the bridge, your ureter contains your urine, it contains your water. So important anatomical relations. Now we've got the round ligament, which helps with the anteroversion of the uterus, connects the uterine fundus to the labia majora. And, some sources will debate and say the round ligament, round stands for like a round zero, it contains zero structures. Technically, the artery of Samson passes just behind the round ligament of the uterus, not in the round ligament. But the reason it's mentioned, the reason we point this out is because this is the anastomosis between your ovarian vessels in your suspensory ligament and your uterine vessels in your cardinal ligament. So you got your arteries of Samson, your anastomosis, which is relatively insignificant. If you remove the anastomosis, it's not going to affect these respective structures. Okay, so just be aware of that. Your broad ligament contains multiple structures. So you've got the mesosalpinx. It's the part of the broad ligament that connects to your fallopian tube. You've got your mesometrium. It's the broad ligament that connects to the uterus. You've got your mesovarium, the part that will connect to the ovaries. Okay. So what's important is to know that occasionally they'll ask which ligament actually contains multiple structures, and the answer would be your broad ligament. All right. So it sounds like a very generic question. But if you know your ligaments, it's pretty easy, okay? Your broad ligament contains multiple structures. It connects to your ovaries, your fallopian tubes, and you have the round ligament of the uterus as well, found at your uterine fundus. You also have the ligament of ovary, which connects the ovary medially to the lateral uterus. Okay, so whereas your suspensory ligament is lateral, your ligament of ovary medial. Fairly straightforward. Now for the flash quiz. A physician performing a hysterectomy needs to ligate which vessels as the suspensory ligament of ovary is cut? As we talked about, the ovarian vessels, which arise directly from the abdominal aorta. So now we're going to talk about the female reproductive histology, and I'll just start off by saying that the areas that can incur trauma or abrasion are the ones that are stratified squamous. You have your vagina, your coitus will have abrasion. Your ectocervix, the part of the cervix that faces into the vagina, also stratified squamous. And that's in contrast with the endocervix, which is simple columnar. You've got that transitional zone, that transformation zone that is subject to development of cancer. Okay, they like you to know that transition, that transformational zone between the ecto and endocervix is where you can get your cancer pathology. They also want you to know that the uterus has these tubular glands, okay? Now, you're not going to be asked in a question, what's the histology of the uterus, and you're going to have to answer tubular glands, okay? What they're going to do is they'll show you a picture. They'll show you these glands that look relatively elliptical, okay? And they'll just look somewhat like this. Believe me, this isn't overly dramatic. You'll just get these glands. They'll look relatively tubular. Look, they're tube. They look like tubes, right? If they show you histology that looks like that, and they tell you it's endometrium, you're going to know you're in the first half of the menstrual cycle. You're prior to ovulation, okay? Now, when these glands get a bit more coily, you can pardon my horrible artistic skills here. When they start to look a bit more coily, like this, you know you're in your secretory phase. That's post-ovulation. And that's what they'll occasionally do. Okay, so they'll show you these glands. They'll show you these tubular glands, and they'll say, what phase of the menstrual cycle are we in? And you could just say, we're in the proliferative phase, in the first half of the menstrual cycle. Or they'll show you these coiled glands, and they'll say, where in the menstrual cycle are we? And if they look just like this, the answer is actually the early luteal phase, the early secretory phase, okay? Synonymous, luteal and secretory. Early. Now, why am I saying early? Because if you see these coiled glands and they show you like these little secretions in there, okay? Once again, I promise you, this isn't overly dramatic. If you do see a picture, it'll be very obvious. But once again, it's not. Histology is one of the lower yield topics on step 1. But the reason we're covering this is because of that histology that is low yield to show up. This is actually some of the highest yield, okay? So I'm just making a point of this. If they show you secretions inside these coily glands, that's late secretory phase, okay? So these tubular glands, like this is the proliferative phase. That's prior to ovulation. They show you these coily glands without secretions. It's early secretory phase, okay? And if they show you these coily glands with secretions, as you see here, that's late secretory phase, okay? And your fallopian tube in your ovary, your fallopian tube has ciliated epithelium. Columnar epithelium is what tends to be line conduits. Cuboidal and columnar can line conduits. Columnar, you know, any type of passageway. Ciliated paired cilia function in Cartaginer syndrome, for instance, where you get that Dineen arm defect and you get infertility or ectopic pregnancy in a woman. You can also have a loss of cilia function secondary to pelvic inflammatory disease, okay, where you get infertility or ectopic pregnancy, right? And just cuboidal tends to indicate secretory function, okay? But once again, I wouldn't stress over the difference here. I would say the main idea to take away is just remember that this is ciliated for your fallopian tube, and that the uterus has this difference in gland structure through the menstrual cycle, and that you get this transformation zone, this transitional zone between the ecto and endocervix, where cancer can arise. So what is the histology of the ectocervix? Stratified squamous. Okay, and the endocervix, as we just mentioned, would instead be simple columnar. So for the female sexual response, the main point you need to drive away from this, okay, you don't need to get all pedantic about memorizing this exact sequence. This is relatively intuitive. The main point, believe it or not, is this uterine elevation. Every once in a rare while, there will be a question about female sexual response, and they'll mention uterine elevation, and they'll ask where in the sexual response the woman is. And some students, if they've never heard this before, they think it's possible it's during orgasm that you have this reverse peristalsis, which does occur during orgasm. You get that reverse peristalsis to help propel sperm. But the uterine elevation occurs during excitement. Okay? So remember that uterine elevation occurs during the initial phase of the female sexual response, and the uterine contraction, which is this reverse peristalsis, occurs during the orgasm. So you get that final maturation of sperm, the increased motility, that it's called capacitance. Capacitance is a term that refers to increased motility of sperm when they enter the vagina, and that increased motility combined with the ferning pattern seen during ovulation in conjunction with this uterine contraction during orgasm augments the probability of a conception.